Good afternoon, and thank you for joining us for today's webinar, How AI Solutions Are Changing Healthcare. Before we begin, I would like to go over a few housekeeping items. Today's webinar will be recorded and available through our website and the RadSite YouTube channel. To minimize noise and distraction, all attendees' microphones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using our QA box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Rene Quashie, Vice President of Digital Health for the Consumer Technology Association. Thank you.
Thank you very much. I'm so looking forward to today's webinar. As was originally indicated, the webinar's title is How AI Solutions Are Changing Healthcare. We have an esteemed panel that's going to dive into a number of issues at the intersection of AI and healthcare. We have Dr. Mark Hiatt, who's the Chief Medical Officer at RadSite, Dr. Eliot Siegel, who's the Chief Innovation Officer at RadSite, Dr. Jenifer Siegelman, who's Principal at Photo 52 Group, and Tom Wilson, PhD, the Chief Epidemiologist at Trajectory Health AI. Among the issues we're going to be discussing today are how AI has evolved and impacted human intelligence, how AI is accelerating change in healthcare, how AI has and is improving medical imaging and diagnostics, and then we'll get a little bit into some of the challenges, such as the relative lack of data liquidity and how we regulate AI. So what I'm going to do is I'm going to have each panelist introduce themselves, a little bit about their experience and expertise. And I want each panelist to answer the following questions as they introduce themselves. And that's going to be, how are AI solutions changing healthcare? Sort of tackle that issue broadly, and then we'll sort of dive in as the webinar ensues. So why don't we start with Mark? Introduce yourself and please answer the question.
Thanks, Rene. My name is Mark Hiatt. I trained as a radiologist at Stanford, where much of the early innovation in medical AI emerged. And I later led precision oncology companies like Guardant Health, while also guiding payer coverage and reimbursement as the medical director for a health plan and as the chief medical officer for a medical benefits management company. So these very positions, Rene, kind of gave me some unique perspective into how really AI has evolved and how it's emerging in healthcare. And I think that from that perspective, I believe that AI is really transforming care by enhancing diagnostic accuracy, speaking as a radiologist, by improving efficiency with respect to adjudications within healthcare, speaking as a former payer. And also, I think really in terms of, and this may be somewhat paradoxical, in supporting more personalized treatment decisions, as I think clinicians are able to avoid the administrative and focus on the patient. And so ultimately, I think that providers may be able to deliver higher quality, more cost-effective care without losing the human touch.
That's a great intro. Elliot?
Hi, thanks. I'm Eliot Siegel. I'm a radiologist. I had the opportunity to create the world's first filmless or digital department. And so even before the rest of healthcare made the transition to the electronic medical record and was still paper-based, we made the transition from a film-based environment, which the rest of the world was doing, to digital. And part of the reason that we did that was to try and know where the images were and have access to images anywhere, anytime. In fact, the joke, that the head of the Department of Medicine, Dr. Makoviak, would make is that, the Baltimore VA has always been filmless because you could never find the films when you needed them. And, really a lot of the transition was for that. But really, we were super excited about the ability to incorporate AI and to be able to enhance images and have the computer help out. Even 30 plus years ago, we were doing mammography AI, and that was an exciting application. And so over the years, I've had the opportunity to be involved with AI in a number of ways, including at the National Cancer Institute, heading up imaging informatics there and creating the National Cancer Image Archive. I was on the IBM Jeopardy team when we crushed Jennings and Rudder back in 2011, and have been instrumental in helping to introduce AI into diagnostic imaging. From my perspective, I think AI is going to be absolutely pervasive in healthcare in all aspects. Mark underscored some of the patient care aspects, but even aspects looking at the administrative running of the hospital. I use AI for contracts, for ingesting information that comes in from the outside in faxes. I think large language models will have even more of an impact on diagnostic radiology and healthcare in general than the algorithms that we'll probably be talking about more that help with making image findings and looking at medical images. So I think it's going to have a major impact in every aspect of healthcare in a positive way. And I'm using AI now routinely in my practice all day, every day. So thanks for the opportunity to introduce myself.
Thanks, Elliot. Jen?
Hi, I'm Jen Siegelman. I too am a radiologist by training, and my journey has also been a little bit zigzaggy. For the last decade or so, I've led a translational medicine group at a major pharmaceutical company in the United States. And in that role, I've partnered with many small startups who've been working developing AI solutions, not only for radiology, but also in the device space and digital pathology space. Before that, I had a brief stint at one of the Boston hospitals where I worked as an emergency teleradiologist covering 16 hospitals each night. And antecedent to that, I worked as a community radiologist where I led a cross-sectional imaging department at a community hospital for about 15 years. So it's an honor to be here. Thanks, Renee.
Great. And Tom?
Oh, I gotta have my answer.
Oh, yeah, that's right. How are AI solutions changing healthcare from your perspective?
So for me, I think the AI solutions are disrupting healthcare so dramatically that in a few years, 5 to 6 years, healthcare will be unrecognizable. Um, I am an early adopter, and I'm also old enough to remember the human-to-human relationships that occurred within healthcare, both for patients to patients and doctor to doctor. I think over the last 15 or so years, that's really gone away, and doctors are looking more at their computer screens than they are at the holistic patient. And so for me, I think my hope is that freeing up some of the laborious tasks that are mundane and workaday will allow the humans to have human-to-human contact. I also think, and this is really promising, that some of those tasks can be taken up by people who have less training. And so the concept of, I don't want to call it de-skilling, but using skills that you have. So if an algorithm can really help humans to do tasks which are hard to recognize but reproducible, I think we'll be able to see better access to care to people in places where they don't have access to, doctors who have previously practiced at quaternary care institutions. So thanks.
Excellent. Tom?
Thanks, Renee. Yeah, I'm Tom Wilson. I'm a UCLA trained epidemiologist, and my main interest over the last 25 years is really the intersection between individual medical management and population health management. There's an essential conflict there. The population health metrics may encourage you to do something to an individual patient who meets the criteria, but not necessarily. So I think there has to be a really good interaction between individual medicine and population medicine. And the thing that I spent years with healthcare companies, with insurance companies, looking at data, making real world predictions. There are challenges with making predictions in the real world, which I hope we address a little bit today. It's not a magical, AI is not a magical solution. And if I say anything at the end of the day, I think humans need to be the final arbitrator of AI tools. They can certainly benefit a lot, but we have to maintain control. So those are my comments. Thank you.
Yeah, I think you sort of touched on the initial question I had, but let's get on to the other question. You sort of started to touch on this a little bit, and all the panels actually touched on this a little bit. How should human intelligence interface with AI? Tom, we'll start with you, particularly given your last comments about how the human has to be the ultimate arbiter.
Yeah, very interesting. Yeah, I just read yesterday the clearance document for a new Apple device that predicts hypertension in people that don't have hypertension. And there's a lot of interesting things in there, but the most interesting is the AI tool is not the final judgment. They say there several times if you are alerted to the fact that you might have hypertension, you need to go see a health care professional to confirm it. So I believe at the end of the day, as I said just a minute ago, the human being has to be the final decision maker here. We can't just turn things over to AI to make all the decisions unless they're 100% accurate. And what I mean by that is 100% sensitivity, 100% specificity. Um, Another thing that I noticed about humans and machines, I studied history before I went into epidemiology, and I'm going to quote Ralph Waldo Emerson, who said in the 1830s, machines are in the saddle and ride mankind. Okay, this is 1830s. The worry there was, all the industrial revolution and all the machines, they're just going to take over human existence. And it just didn't happen. And I don't think it will ever happen unless we let it happen. And I don't think we will let it happen because there'll be too many mistakes, I believe, the machines will make, and we will have to correct them. So, um, those are my introductory comments, and I'd like to hear from the rest of the panelists about some specific items listed on this slide. Thanks.
Yeah, Jen, I saw you nodding your head. Do you want to weigh in on what Tom had to say?
Sure. So I think, Tom, I agree with you on one hand that it's ideal to have humans in the loop. But I think that a belief that a human is or all humans are 100% sensitive and 100% specific is a higher bar than actually humans achieve. And we've seen this in tons of studies. Even the within you're an epidemiologist. I don't have to explain to you, if I do the same task on 2 days, I might do it slightly differently. And so for me, I think this is an interesting paradigm. In thinking about, where we are today, understanding where we were 2 years ago when everyone in sort of the commonplace was not aware of the use of generative AI and large language models versus today. I think that that's kind of a pivot point that we might want to think about in terms of can a machine actually behave like a human or a friend or a chatbot? Yeah. So my thoughts.
Yeah, and Elliot, before I come to you, Tom, it sounded like in your comment you were placing a higher burden on the machine than the human. Am I overstating what you said or misinterpreting it in any
Let me
way?
just, well, in a way, I think a lot of people think the machine will be better than the humans. But equivalence is pretty good. Like I agree with Jenifer, we're not going to get 100%. We don't have 100% sensitivity and specificity as human beings. But if there is a disagreement between the machine and the human being, I think we need to have a discussion. And I'm not sure who the discussion is with, but there needs to be a discussion. I'm also reminded of, William, the Southern writer Faulkner, in his Nobel Prize-winning speech in the 50s, and he said, "Man will not only endure, he will prevail." So, I don't want to put too much credence on the value of AI in replacing the human being, at least in the world of healthcare. And what I've noticed in healthcare, by the way, is, and we all know that human beings, no two are alike. It's not like the jet engine that rolls down the plant here in Cincinnati making, General Electric plants. They're all different. And there's going to be some interesting nuances. And I think AI and HI and AI can work very well together in solving some of these issues.
Elliot, Mark would love to hear from you.
Good.
Uh-oh,
Well,
uh-oh, that didn't sound good.
well, I think from my perspective, I'm both a radiologist and an oncologist. I do radiopharmaceutical therapy and have actually recently established a national practice. And whether I'm working at the hospital as a radiologist or working with patients or consultants as an oncologist, I work with all sorts of humans. I work with medical students, I work with residents, I work with fellows, and they all perform at different levels and they all give me advice and they all, collect information. They all end up processing the information. And so I'm used to having different levels. They all help me, even if they are not necessarily 100% accurate or necessarily even better than me, they still add tremendously to what I do from a cognitive perspective and from an efficiency perspective. Any of the things that I have a computer do, for example, finding lung nodules on a CT scan or hemorrhage in an intracranial CT scan, whatever I do, I could send out to humans to essentially interpret for me and then have that come back. And lots of people will send out MRI scans, musculoskeletal, and other to consultants to get answers. But ultimately, I'm responsible. And any consultant I send things out to, I have to understand that it's my responsibility ultimately to make the decision. So, I think of AI in a similar manner. We don't have requirements for the consultants necessarily to have certain levels of accuracy. It's up to me and my judgment to pick and choose those. My car, my Tesla from 2015, has been getting smarter incrementally every few months as time goes on. I'm still at the wheel, I'm still responsible. But here in 2025, the car does 98% of the driving for me, whereas previously it was maybe 5 or 10% or so. And so I've learned as a human to be able to interact with it, understand what it does and doesn't. And as it's grown and gotten better, it has helped me and saved me from, accidents or hitting a deer or stopping faster than I could have. And so it's a great tool, but I agree that a human in the loop for driving and a human in the loop for making decisions about patient care, at least here in 2025, is really critical. But we humans need to learn how to interact with AI, and the way that we teach our medical students and residents is going to change dramatically as these tools become prevalent.
Yeah, Mark would love to hear your perspective.
Yeah, I agree with Elliot that there, different levels of contribution, whether it be from a human, such as a medical student or a resident, or an artificial intelligent tool. But I think ultimately the important thing, at least in 2025, that there needs to be someone in that driver's seat to take that feedback, to take that information, and to be the ultimate judge. And in many cases, you can just let that Tesla drive on its own. But you've got to have someone in the driver's seat as the ultimate judge for when maybe the 1 out of 100 or the 1 out of 1,000 decisions made by the tool, whether it be human or artificial, whenever that's a wrong decision, there needs to be some ultimate judge, which is you in charge. And so as pertaining to administrative decisions within healthcare, increasingly many health plans are using artificially intelligent tools to digest data, the medical record, to digest the appropriateness criteria of a medical benefit management company, and then to spit out an adjudication, whether or not that requested procedure is warranted by the clinical scenario. And I think maybe the vast majority of times that's an accurate adjudication or decision, but there still needs to be a human in that driver's seat because that computer still in 2025 lacks one essential trait, and that is human empathy. And to be able to empathetically understand and make allowances depending upon the human condition of the patient. So that's just one example where I think we still need the human in charge because of these unique traits that we as humans can have.
Wow, very, very well said. So Jen, I want to turn to you, and if we can move to the next slide. You sort of touched on this in your intro, but what changes have you seen in healthcare because of AI? And particularly, I want to focus on the clinical end of things. I think sometimes when we talk AI and we have these AI conversations, we tend to focus on the administrative and professional side of things. But let's start off by focusing a little bit on the clinical side of things.
Um, so there Of course, everyone listening has had an experience with AI in healthcare in one way or another. Something that I find fairly exciting, pretty exciting, is the use of AI to help pathologists discern whether cancer, for example, prostate cancer, is present in biopsies. So it's a boring job looking at cells under a microscope and multiple biopsies, every day in and day out. So there are algorithms now that can really help pathologists say, hey, cancer's likely present in this slide. So I think that's very important. It's also seen in breast cancer, where we understand the estrogen and ER and PR positivity of a slide, and whether the cancer will respond to certain chemotherapies, and also true in lung cancer. So for me, that's a place where people who have cancer are likely getting better care, more accurate care for the types of tumors that they have more expediently. That's one way. Another way I think about it is I was out to dinner with a friend who has type 1 diabetes, and they wore a diabetes pump, an insulin pump. But that pump actually is a highly educated pump that learns from what her body has done previously in response to the insulin when she eats, rice with her dinner. And so for me, that's another place where AI has really, made inroads. We're talking about big diseases that affect, many, many thousands of people. Another area where I think that I've been quite excited, and I alluded to this in the beginning, was I went to the doctor myself and I saw actually my doctor's face. I was actually able to have a conversation with her because she had an AI ambient listening system
Hmm.
recording the conversation and producing some form of note so that she didn't have to copiously, take notes for the entire time that we were visiting. So I think in these areas, it's very relatable. These are real world examples of how AI is part of the healthcare system and potentially really improving the healthcare delivery system. And I think incontrovertibly, whether or not they work perfectly, there's a change that makes the lives of both patients, in the case of the ambient listening, and doctors a little better.
It's very well said. And so, Elliot, I want to come to you. So let's take radiology off the table for now. In
Sure.
your view, where else has AI really shown tremendous benefit?
Yeah, so if I put on my hat as an oncologist, then one of the challenges that we have in the outpatient environment is that, we're not inside of a system like Mass General or University of Maryland or Hopkins where all the data is self-contained. Every time we see a new patient, and 65 to 70% of all cancer care takes place on an outpatient basis. There are no standard ways to send information. So patients arrive almost invariably with huge amounts of data that are faxed to the office, 200, 300, 400 pages or so. And in the past, one has needed to have a nurse practitioner or somebody in the office go through all of that, organize it, structure it, and then the physician doesn't have to spend 3 hours necessarily pouring through and organizing that information. Well, introduced to our practice, it takes somewhere around 12 seconds or so to take 400 pages of information and create a really good organized synthesis of what's important to know about the patient in a structured way. That's changed things dramatically. Not only does it do that, but out of the box, large language models that exist, and we use HIPAA compliant version of Google's Gemini, but out of the box, they're able to then create recommendations and insights from the information that maybe or maybe not, we would have thought of. Issues related to drug interactions, issues related specifically to personalizing how we might provide care to the patients. As we practice and collect genomic information, lab information associated with imaging data that we get as oncologists, all that information can then be used to personalize or make precision recommendations for each patient. When a patient asks a question about how they're likely to do when they're treated in oncology, it's not just saying, well, kind of in my experience, people have done fairly well, or hey, there's a clinical trial, or hey, there was something that was written in the literature. The patient says, but how about me? I mean, I'm in really great shape and I don't have family history, etc. And so being able to personalize it using data, using these large language models and other AI systems is revolutionizing the way that we practice in oncology outside of radiology. So, whether or not I've got my hat as a radiologist or as an oncologist or administrator or head of a startup company, in all of those ways, AI applications are revolutionizing the way I practice.
So, Mark, taking the non-radiological examples that Elliot just talked about, let's turn back to radiology and walk us through because when we, for example, the FDA has approved something like 1,200 closed loop AI tools, and a
Mhm.
huge percentage of them have to do with radiology. I think something like 80 something percent of them. So obviously AI and radiology have gone together for a long time. So sort of dive into that a little bit and provide us some context of how AI is being used in radiology today and where you anticipate it going in the future.
And Rene, that's exactly right. Radiology's they're right at the apex in terms of FDA adoption or approval of applications pertinent to radiology, with cardiology and oncology following behind at a much smaller percentage. And there are numerous applications of artificial intelligence, specifically in radiology, foremost of which I think is enhanced accuracy and earlier detection. So there are now AI algorithms that can flag subtle abnormalities which my human eye could miss. So in my interpretation of the CT scan of the abdomen, I may be looking at the principal indication for that exam. Maybe it's a right upper quadrant pain. But in that process and in my speed of trying to interpret that study, I may not think of all the peripheral things that are available in mass on that scan. For example, you can find out information about the fatty infiltration of the liver, and you can have these algorithms that will automatically measure and flag those things that I might otherwise not have at the forefront of my mind. So you provide extra information to the ordering clinician that he or she wasn't even expecting. So one example of this, Rene, is within the realm of breast cancer screening. So on a mammogram, you have this information, of course, about these things such as microcalcifications and early lesions that may be precursors to malignancy in the oncologic domain. But it's interesting that women will actually die from a disease much more prevalent than cancer, heart disease, arterial calcifications for which are apparent on a mammogram. And so there are now, companies that actually automatically do this background work for the radiologist to give information about the presence of those harbingers of potential heart disease. So in essence, AI has enabled a 2-for-1 mammogram, as an example. Now, as we'll see on the next slide, an additional aspect or benefit of AI in radiology is also the improved efficiency and workflow. And so radiology can automate all those boring tasks. It can triage, it can do the measurements, it can even help with reporting. It can reduce turnaround time so that you have earlier reporting of your results. Also, technically, it can enhance imaging quality. And so there's things that AI can do behind the scenes to reduce the noise, the reconstruction techniques that can automatically be performed to improve the clarity at lower radiation doses to assist the radiologist. And so there's numerous things that could be done. And this is just scratching the surface, Rene.
Well, can I ask you a question though? It seems like what you're describing is greater efficiency, right? You talked about turnaround times and everything else, but aren't practicing physicians worried then payers are then going to put more pressure on you to see more patients and actually do more work since you can do it in less time than you used to be able to? Is that a concern?
I think that is a concern. I think the larger concern of radiologists or any diagnostician, a pathologist, is that they will be displaced or replaced by these new tools. And I think going back to our earlier conversation, about the ever-present need for a human in that driver's seat behind the Tesla, I think that will always hold true. also in these specialties of radiology and pathology. As to whether our payer will somehow expect greater, I don't see that as a current pressing concern, although I defer to my fellow radiologists, Dr. Siegel and Dr. Siegelman.
I'll give my 2 cents. I do think that improved efficiency, the number of minutes that a radiologist spends evaluating a particular exam, is measurable. And if something is measurable and monitored, then those in charge will likely put a price tag on that unit of time spent producing a particular examination. And as many know, the relative value unit, RVU, is a metric of this. And so while I agree with Mark, it's really important to have humans in the loop, and that radiologists 10 years ago might have been worried about being pushed out. I think now it is a concern, Rene, and I think you're spot on that with improved efficiency, we're in kind of a honeymoon period where ambient scribes or things that help you not miss fractures of bones when you're reading a CAT scan or incidentally detect osteoporosis risk. These are very wonderful things, but at some point, the lines of the graph will cross, and somebody will shake their head and say, are radiologists being paid more per minute than they were previously because the artificial intelligence solution is taking up some of the burden of the work? I think it's a wise thought. I'm not sure, I'm not a mathematical modeler and I don't have a globe crystal ball.
Yeah, Renee, that a lot of this reminds me of 32 years ago or so when we made the transition to digital. And a lot of my colleagues in radiology said, oh, you just killed radiology for everybody because of the fact that, oh, images were going to be available not only in the radiology department, but anybody could look at them. But that turned out to only increase people's enthusiasm for, requesting additional studies, and volume grew. What we've seen with the transition from film to digital is that, Mark and Jenifer can read a 1,000 image CT scan in the same time, and maybe 1/3 of the time it took to read a 40 image CT study. And so efficiency is incredibly higher. The number of studies and images is much higher. But what we've seen is as efficiency increases, complexity of the studies increase. And so we're seeing more images, we're seeing, more sequences with MR, we're seeing more complex three-dimensional multimodality imaging. And so, what I've seen is actually what might be counterintuitive, and that is you end up having instrumentation that becomes more sophisticated. You end up having greater complexity and greater expectations. And that over many years empirically has kept reimbursement, relatively similar to what it had been before. So I think if you just look at the idea, yeah, we're twice as efficient, we're going to make half as much money eventually per study, that has not actually been borne out as we've made the transition to digital. And I really don't anticipate that that's going to happen. In fact, radiologists are in shorter supply than ever, and AI has allowed us to actually have studies read in the US, whereas in Israel and the United Kingdom and other places, they do imaging studies that never get read by anybody. And essentially, they get a note saying, well, if you need somebody to read it, go find a radiologist.
Yeah.
So, I'm a lot less pessimistic that we're going to be seeing major decreases in reimbursement rates for radiology, at least in the next 5 to 10 years.
That's interesting. We've been talking about AI, and it seems all of you are very bullish on AI. Tom, I want to bring you into the conversation. One of the things people always talk about is the accuracy of AI. Can we trust what the AI solution is telling us? So I'm going to put
let me make a comment on the previous slide.
Sure.
Because I know we have a lot of radiologists here, and therefore we talk a lot about radiology. But one of these, go to the previous slide. Where?
Well, keep making your point.
Let me just. Back one, where it talks about medical, because I do medical research, right? It says implications on medical research. I just want to make a comment. I did work for many years with a real world oncology clinical center, very large, and we did a lot of research. And 10 years ago, we would do manual extraction of physician notes, right,
Hmm.
to do our research. And now, more recently, we're going through with AI, natural language processing, and pulling out automatically all these records. Now, and I think that's fantastic. But back to Jenifer's point earlier about the physician. Physician in this case we called the physician's notes the gold standard, right or wrong. They were the gold standard because we use NLM, natural language processing. We go and they're looking for 80% accuracy, right? And so there's an issue that less than 100% accuracy has implications for medical research. I just want to throw that out, and we don't know what that is yet. And another thing I want to point out is the last item on here, resource allocation. And I talked to Mark Hiatt about this the other day. We may have very accurate tests, high sensitivity, high specificity, but the return on investment of those tests completely depends on the prevalence, the underlying prevalence of the condition in the population. If you have a prevalence of 50%, your return on investment could be much higher than a prevalence of 1%. And I think there's a lot of articles written about this problem, that physicians tend to underestimate the predictive value of a positive test and stick with the sensitivity of the test. So resource allocation, I think, is going to be a big deal because we overinterpret what accuracy actually is. So that's just on the now. What else? This
Accuracy of AI solutions,
Yeah.
I assume it's a sort of a trick question because it assumes that AI is accurate across all disciplines, across all work streams, right? So maybe it's a trick question, but maybe you can parse it out for us a little bit.
It's not a trick question. It's what is accuracy, right? And accuracy is typically seen as some combination of sensitivity and specificity. Sensitivity is the percent of people who tested positive who actually had the disease, right? So the denominator is people with the disease. The predictive value of a positive test is among all the people that tested positive. And that could be a very, very different answer than sensitivity. Um, and so I think a big problem, a big issue with accuracy is the transparency of the accuracy metrics you're using. And if I can quote the CTA standards that were just released the other day on accuracy of AI, explainability, like if I say it's an 80% accurate test in terms of specificity, well, what is the accuracy in terms of the predictive value of a positive test? It could be really high, it could be really low. And we need the consumers, the people that use these tests, these predictive tests, physicians, consumers, etc., to understand what's going on here, and payers. I mean, I think this issue of resource allocation is going to be huge as we do more and more and more tests, and we get more and more false positives and false negatives, and we have to pay for the test if you're true or false. So that's one. I think we need more transparency, and I think the Consumer Technology Association standards that were just released is a wonderful framework around which developers of AI tools can announce to the world, what they've got in a basic kind of way.
So if you're a clinician now, how do you know how to validate and evaluate the solution, the particular solution you're using? And I'll throw it out to the physicians in the group. Mark, maybe you can talk about this.
I was thinking more, Rene, speaking as a clinician and a former payer, a lot of times clinicians take their lead from what evaluating payers determine because that's the source of their income or
Sure,
reimbursement. And
sure.
so speaking as a payer, I agree with Tom. There's a real challenge in determining what value AI brings to, say, diagnostics. Increasingly, there's a trend within the world of payers to incorporate and embrace real world data in the determination of the efficacy of a novel diagnostic technology. And so here the famous mantra of the Blue Cross Blue Shield Association has been, what is the improvement in net health outcome of a contemplated technology? And you use real world data to determine it. So you hopefully in that way somewhat address the challenge that Tom raises to actually see at the end of the day or at the end of the year or at the end of the 5 years or 10 years, what is the long-term consequence of a incorporation of a novel AI tool in the health and welfare of a patient population? And so I think then payers will construct their medical policy accordingly, their reimbursement policy accordingly, and then clinicians may receive at least some signals from what payers will pay.
Interesting. So it sounds like the payer really has oversized influence here because they've got the purse strings, is what I'm hearing you say, right, Mark?
Unfortunately, sometimes yes.
Interesting. Elliot and Jen, do you have any reaction to that?
Yeah, I do. So I think there's a number of things to consider. One thing to consider is I think that those 800 plus applications that you talked about with, over 1,000 and 80+% that are cleared by FDA, it's going to be really interesting to see what happens in the future because more and more large practices like Rad Partners and also RadNet and VRad are developing their own AI algorithms and they're utilizing them. And so a large amount of the outpatient practice is actually utilizing in-house algorithms that are developed on in-house data that may not go through FDA clearance and may not necessarily require, payer reimbursement. And there are entities now that are creating foundation models that will allow individual facilities, medical centers, outpatient practices to develop their own algorithms. And people are increasingly looking at when they purchase their PAC systems, having those algorithms that are included also. And so, it's a separate question about a commercially approved algorithm where I can at least ask my colleagues, how did it perform or take a look at when it was cleared, how well did it do? I can ask questions potentially about what patient population was it tested on? Was it similar or different than mine? Those are all factors that are important for me. And then I want to evaluate how well it's done in my own practice by creating a feedback loop in my practice. But what's happening is people are now looking at inherently utilizing their own data to develop the algorithms, which will, by definition, essentially be optimized for that particular practice and then tested as they are developed and then tested continuously. So I
Hmm.
think we need to look at both models. There are so many AI applications now that are possible that 800 is only going to begin to scratch the surface and people are going to be utilizing their own. We have a number of algorithms in the Shock Trauma Center at University of Maryland that have been developed, have not gone through the FDA process, but that we're using internally because we have a huge database of those patients. So I think it's important to look at the two different types of algorithms bought and then produced locally. And in any of those cases, it's really important to have a mechanism for feedback from those who are utilizing the algorithms. Now it's mostly the radiologists who are using the radiology applications, but it's going to transition to being the non-radiologists that are consuming these applications for diagnostic imaging studies.
Yeah, Jen, do you want to weigh in?
Sure. So I like what everybody's saying, but I want to raise a sort of counterpoint, and that is we don't have feedback loops for the measurement, let's say, of magnesium. What is your magnesium level? We have objective standards that are produced and held by the NIST or an external governing body that says this is a standard. And so when we talk about homegrown algorithms or FDA approved algorithms, when the Food and Drug Administration approves something, they approve it for a particular intended use. So it shall do a certain thing under a certain set of conditions. It will detect pulmonary nodules if the CAT scan is done in this particular way, and the lesions are between size X and size Y of density, Hounsfield unit, whatever. So the question of performance in my environment and the emotional feeling that radiologists get about it being good enough or not good enough is really kind of not a high enough bar for me if I'm thinking, as a public health professional with a different hat and saying I want to protect patient safety. I think that the bar might need to be a little bit higher than simply feedback loops from, well-intentioned radiologists and well-intentioned other physicians who are consuming the radiology interpretive process or quantitative process. What does everyone think of that?
Well, the problem is then who becomes the steward of that? The is the steward the FDA? I mean, the FDA goes out of its way to say that they don't want to tell people how to practice. And, the FDA goes out of its way to say they're just looking at the process and the claims and they're certifying the process, but they're not in any way weighing in to the medical practice. So then does it become the American Board of Radiology or other boards? It's because you're really talking about clinical performance. And so who really should be the steward of that? Is that regulatory? Is that the clinical society? Should that be the American College of Radiology or the Radiologic Society of North America? So I think that's the challenge. And then if you do that, then do you prohibit folks from developing their own homegrown applications? And if you
Well,
don't,
that's a great set of questions that I'd like to get to at the end when we talk about regulating AI and
yeah,
because I actually don't think we have the regulatory infrastructure to do some of the things you're talking about, Elliot. We just don't.
yeah, and that's my
Besides,
point.
yeah, and besides which the FDA doesn't have the resources or personnel to do any of this.
Yes,
They can barely keep up with what they have.
yes.
Tom, we were in an event last week. I want to pivot a little bit, and we heard from Chris Klomp, who runs the Center for Medicare at CMS. And he was asked what his number one focus area, and he said the term data liquidity. And before I turn it over and ask you about the AI implications of that, what is data liquidity?
I mean, yeah, I think data liquidity is the ability for data to freely move between different environments for, use for basically any approved thing, So what Eliot just talked about, these homegrown AI solutions, or even if it's an epic AI solution, it's still in a closed system, right? How well do these things work in another system? How accurate are they across the board? And what we may need, and I just thought of this just now, is some generalized database that people supply where we can test our algorithms with a standard database to see how well Eliot's AI tool compares to Mark's AI tool, compares to Jenifer's AI tool. So that's one thing I think is important. Another thing, and I worked in data my whole life, and data is in the real world, it's really messy. There are a lot of problems that are essentially input variables to AI models. There's missing variable, there's incompleteness. As we all know, the whole patient journey is usually not included. There's a lot of missing information, but we do what we can, right? So what I wanted to talk to the guy at CMS the other day is, well, we don't have full data liquidity. So how do we behave when we don't have that? And we don't have that, and we probably won't have it for a long, long time. I mean, pure data liquidity. So what I just proposed is a way to compare different applications across different sectors to see how accurate they are. Because at the end of the day, to me, it seems accuracy is really significant here and return on investment.
Yeah,
Yeah,
I would argue that data is incredibly non-liquid in healthcare more than virtually any other industry. I mean, if I have somebody who comes into the emergency room with a rash, um, and I want to determine whether or not that patient's had a rash before, I can open up and look at all their prior notes. But if I want to go back and find out whether all patients who come into the ER in the last month have had a similar rash and where they are, there's no capability to be able to do that in our current electronic medical record systems, much less the portals that essentially are associated with each medical system that really don't allow one to be able to cross data from one to the other. And if you're trying to do research or trying to do clinical care, it's extraordinarily difficult to get access to data. If you're a researcher, it's difficult. Healthcare data under, partly the protection of patients' privacy and security, but also under the guise of privacy and security, ends up having so many walls that are built around it that actually hamper our ability to be able to use data to make decisions to help our patients.
So I want Mark to weigh in here. So if we accept Eliot's premise, which I think we all do, that this is a really data um, solid environment as opposed to a data liquid environment, how does that impact AI development in the future?
The fact that instead of having a data lake, we have little data puddles separate from one another, inaccessible, where we don't have true access and interchangeability so that we can make high-level decisions with a large sample size. This is a true problem, and it's a problem perpetuated in healthcare. So I'm familiar with integrated delivery systems that purposely use the facts and don't want integration because that's their proprietary moat to keep clinicians from outside the network, outside the system,
Yeah.
from penetrating those walls. So this is a perennial problem within healthcare, which still uses the fax machine for that very purpose. And so there have been attempts. I've served as the chair of a state's Digital Health Service Commission, along with the mentioned Chris Klomp in my state previously, where that was the real challenge that we fought. And in terms of overcoming and making those puddles coalesce into a true data lake, one solution is an external one, and that is there's these various companies rising up that actually curate across the nation and world databases of those patients with a rash that come in. And there's one in particular, AlphaCure, that curates all the patients across the nation who have had multiple myeloma, what their path was, how they were treated, how they responded. And that information serves, I think, as Eliot is intimating, a helpful repository of information that could be mined through AI for the benefit of the new patient with multiple myeloma.
Interesting. We only have about 8 minutes, so I'm going to ask one last question, and if you guys could sort of keep it brief, maybe 2 minutes each. Um, in your view, as you think about AI and all the sort of opportunities we've talked about, some of the challenges, do you think AI can lead to better health outcomes today? And if we were to look in our crystal ball 5 years from now, how will AI have impacted healthcare generally? Jen, we'll start with you, and again, 2 minutes each, and then we'll close out.
So I would say that the use of the term outcome here, we've got to be very careful because it is, in fact, a term of art. And an outcome for a patient is not a process measure in radiologists' quick turnaround time or happiness or any of the above. An outcome is really something solid and foundational. In the context of cancer, it's a life saved, or perhaps a life that continues without cancer, a heart attack averted, things like this. And so when we look at the peer-reviewed literature in the space of outcomes associated with AI interventions, in particular radiology AI interventions, the literature thus far is scant. We have single institution studies that tell us perhaps that, patients may have a better in-hospital survival from pulmonary embolism. There's one small study that looks at that, but we don't have head-to-head randomized controlled studies where AI was used and AI was not used. And the way the world is evolving as a natural laboratory with AI present, it's improbable that we will be able to ethically and practically run these head-to-head trials within an institution. So I do think, just based on my understanding of, and my belief that an early detection could lead to an early cure. Now, that's not a proven fact in every disease state, but in knowing that that is sort of a basic tenet of medicine, we can believe perhaps that there will be better outcomes. But I think what's super interesting, and Eliot made reference to foundation models before, is that when foundation models, that is, models that incorporate the totality of known information about a patient's health and life, are available, and liquid data is available, we'll be able to get a better handle on whether, in fact, there are inflections in patient outcome based on the data. And I'm optimistic that given the speed with which the technology is advancing, we're going to get there sooner than we think.
Great. Eliot, a couple of minutes.
Yeah, so I mean, I agree with Jen that it's difficult to measure outcomes and you have to really define that. But I strongly believe that healthcare practitioners improve patient outcomes. And so I also then believe that if you can promote access to care for patients, if you can decrease waiting times for patients, if you have the capability of being able to democratize expertise in such a way that whether you're in a rural practice or whether you're at Hopkins or Mass General or wherever, you can have relatively similar access to expertise, then I believe it will inevitably result in better outcomes. And I'm incredibly optimistic as somebody that's using it in virtually every patient that I interact with, that it will indeed improve healthcare outcomes. I think we need to have the wisdom to be able to figure out how to best manage AI and how to balance between privacy and security and AI applications. But I'm absolutely super optimistic about its ability to improve outcomes in healthcare.
Wow. Mark.
Wow. Renee, in terms of the outcome of AI's impact on healthcare outcomes, although as a radiologist, I can see right through you, I can't see into the future. So I do have the benefit of an X-ray machine, but not a crystal ball, but I'll do my best. I really think that, like Eliot, I'm optimistic about the power of AI to transform the future and improve healthcare outcomes. But I like to give the caveat that the technology is only as powerful as how we apply it as humans. If I believe that if we thoughtfully keep patients at the center, ensure transparency, address some of those challenges that Tom has discussed with respect to accuracy. If we integrate AI thoughtfully into our clinical workflows, I think that we truly can reduce friction, we can expand access, and we may be able to deliver care that's not only smarter and faster, but also more human. Where, to Jen's point, we can actually see our clinician's face because she or he is freed from some of these administrative burdens because of AI.
Right. Tom, you're going to close us out.
Wow, yeah. I first of all, I believe, I hypothesize that AI will produce better outcomes. But the question is, how do you measure something like that? And in my world, we do the counterfactual, right? Like you want to know what happens when we don't have AI versus what happens when we do have AI, and you compare the difference on two equivalent populations. If we can't do randomized controlled trials, we can do some adjustments to make them as equivalent as possible. So I've heard, for 30 years that healthcare is going to produce better outcomes, but haven't necessarily seen it across the board. Certainly from the perspective of the payers, government payers or private payers, if you think of outcomes as an economic benefit, healthcare costs keep going up, 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 up. And so I think we need to design a framework by which we define what outcomes we're talking about, and then we measure what happens with AI, and we estimate what would have happened without AI, and that difference is the value of AI.
Fascinating. Thank you so much. I learned so much. Phenomenal panel. It's interesting. We just did a clinician sentiment study on AI at CTA, and very, very positive and optimistic view by most clinicians about the ability of AI to help them in their work and to help patients in the long run. There are a lot of challenges that we're going to have to overcome in the interim. But again, thank you. It's been a fascinating webinar, and everybody have a tremendous week.
You too. Thanks so much.
Thank you so
Thanks.
much. Take
Thank
care,
you,
everybody.
everybody. This has been a very, very, very interesting discussion. I feel like we need a part two. RadSite would like to thank our moderator, Rene Quashie, and our panelists, Mark Hiatt, Eliot Siegel, Jenifer Siegelman, and Tom Wilson. Just a reminder, today's webinar has been recorded. If you enjoyed this presentation, be sure to visit our webinar page on RadSite's website or our YouTube channel for this webinar recording and past webinar recordings. Thank you for joining us today, and we look forward to seeing you again at future webinars. Thank you so much.